and I'll be acting as your moderator for the webinar this afternoon. For those logged on and listening, there are some directions we'd like to follow in order to run our presentation as smoothly as possible. Firstly, as you've logged on, you should have been automatically placed on mute. We would like to ask that you remain on mute at all times so that we can minimize any extra noise for others to hear optimally. Also, we will have a question period at the end of the presentation. If you have questions as the presentation is going on, please type them into the question box on the right side of your screen. At the end of the presentation, we will go through each question and answer in order. Today, I'm privileged to introduce our Acting Medical Officer of Health, Dr. Daniela Kempkins, who will be presenting for you. Dr. Daniela Kempkins was appointed as Halton's Associate Medical Officer of Health on October 12, 2016. She joined us as of January 2016 as a senior resident from the Northern Ontario School of Medicine's Public Health and Preventive Medicine Residency Program. Daniela has successfully completed her specialty training with rotations here in Halton, as well as with the Sudbury and District Health Unit and the Department of Health in Nunavut. As of January 1, 2017, she is Acting Medical Officer of Health, while Dr. McGanny is on parental leave. Before moving to Canada, Daniela worked as a medical officer in the Child Health Division of a local public health unit in Germany and was affiliated for many years as a research fellow with the Competent Center for General Practice and Outpatient Health Care at a German university. In Ontario, Daniela worked on a number of public health projects, including housing complaints in marginalized populations, school health and developmental assets, as well as leading efforts to improve the enforcement process of the Immunization of School Pupils Act. Daniela is passionate about public health and especially interested in health equity and how it applies to all areas of public health. Sorry for that. As with all our work through the Health Department, we're committed to work together with the Halton community to achieve the best possible health for all. In Halton, we have the FASD Collaborative, the Halton FASD Collaborative, which consists of dedicated professionals and parents who represent 31 Halton-based service agencies. Their mission is to work together to promote a system of care for the well-being of individuals at risk or living with the effects of fetal alcohol spectrum disorder. Throughout this presentation, we will be referring to fetal alcohol spectrum disorder as FASD. So let's begin. I'll now hand things over to Dr. Kempkins.
Hello, everyone. Today, our objectives are to discuss the importance of routine alcohol screening, especially for all women of reproductive years, for the purpose of preventing FASD and chronic diseases. We would like to review some of the low-risk alcohol drinking guidelines messages for alcohol use related to women of reproductive years. And finally, we will explore Halton resources that are available to support patients and families with substance use and FASD concerns. To begin our presentation today, I would like everyone to think about their current approach related to alcohol screening with women of reproductive years. Think about, when do you discuss alcohol use with female patients from puberty to menopause? Is it if there are risk factors identified for alcohol concerns during an initial prenatal visit, at every visit, or at a physical exam? This presentation is to encourage the evidence-based practice of a collaborative discussion of alcohol use and related risks with all women of childbearing years, as well as with their support networks. It is one part of a four-part framework for FASD prevention and promotion of women's and children's health, which was published by the Public Health Agency of Canada. The other parts of that framework include raising awareness, specialized prenatal support, which would be support for pregnant women with substance use problems and other health and social problems, and lastly, postpartum supports for mothers with alcohol problems. So why are we focusing on women and alcohol? There are several good reasons for healthcare providers to focus on alcohol use among women. Over the years, there has been an increase in the amount of alcohol women are consuming. Many women are drinking above recommended guidelines, and they are more vulnerable to the effects of alcohol, which puts them at an increased risk for long-term health effects, injury, and harm. And lastly, it is to prevent alcohol-exposed pregnancies. With the following slides, we will look at each of the three reasons in more detail. Based on the recent report, Alcohol Consumption in Halton, which was published in January of this year, we know that 3 out of 4 women of reproductive age, which are the ages of 15 to 49, are regular to occasional drinkers. In this report, a regular drinker refers to someone who drank once per month or more in the past year, and an occasional drinker is defined as someone who had drunk less than once per month in the past year. These definitions are based on the Canadian Community Health Survey. In general, alcohol use among women in Canada is increasing. According to the Canadian Addictions and Mental Health Monitor e-report from 2014, in Ontario, 74% of women drink alcohol, and there was a significant increase in daily drinkers among women who drink, from a low of 2.6% in 2001 to 5.6% in 2013. Women who drink are also drinking more. 3 of the 5 Canadian low-risk alcohol drinking guidelines are specific to women. They state that women should drink no more than 10 drinks per week, with no more than 2 drinks a day on most days. They also recommend not to drink more than 3 drinks on any occasion. And if you're pregnant or planning to become pregnant, the safest choice is to drink no alcohol at all. In Halton, according to the Alcohol Consumption Report, we know that 35% of adult women 20 years old and older exceed these low-risk alcohol drinking guidelines. 12% are heavy drinkers, which means consuming 4 or more drinks on at least 1 occasion per month. When we look specifically at women aged 15 to 49, in other words, women in their childbearing years, we see that 44% of these women are drinking above these recommended guidelines. Other research has found that among Canadians, not specifically women, the use of alcohol tends to increase as income increases. The same is seen with an increase in years of education. The 2017 report by the Halton region similarly found that Halton residents with higher incomes were more likely to have drunk heavily or exceeded the low-risk alcohol drinking guidelines in the past year. However, the Halton report did not find a statistically significant association between education and heavy drinking or exceeding the guidelines. Another reason to focus on women, although on average males drink more than females, is that women are more vulnerable to the effects of alcohol than men. Women achieve higher concentrations of alcohol in the blood and become more impaired than men after drinking equivalent amounts of alcohol. Women absorb and metabolize alcohol differently than men. The effects occur more quickly and last longer because women tend to weigh less, which means they reach higher blood alcohol levels. Women have more adipose tissue, causing the alcohol effects to take longer to wear off. They have less water in their bodies to dilute the alcohol and have lower levels of enzymes to break down the alcohol. Overall, women are more likely to exhibit major health problems related to alcohol in a shorter period of time. For example, women are more susceptible to alcohol-related heart disease, and the risk of stroke is at least double the risk of men. Women are more likely to develop alcoholic hepatitis than men. Alcohol consumption can increase the chance of developing certain types of cancers, such as colorectal, some cancers of the central nervous system, and cancers of the larynx, pharynx, esophagus, and liver. Research has found that 1 drink per day can increase the risk of breast cancer for some women. But alcohol can affect more than the individual who drinks. Alcohol may affect a fetus at any time through a pregnancy, including early in pregnancy before many women confirm that they are pregnant. Alcohol use during pregnancy is strongly related to alcohol use before pregnancy. According to a study highlighted by the Center for Disease Control and Prevention, the highest prevalence of any alcohol use by pregnant women is among those who were 35 to 44 years old, college graduates, and those who are not married. As we have just seen, the guidelines recommend 0 alcohol as the safest choice during pregnancy. This is an important component of FASD prevention initiatives. Providing access to effective forms of contraception is also important in preventing FASD for those not intending to become pregnant. About half of pregnancies are planned. Healthcare providers can encourage women to create a reproductive life plan, a tool to assist individuals in developing personal goals as to whether or not, when, and how to have children. The reproductive life plan can be used by healthcare providers as a communication tool regarding contraception and preconception healthcare. A reproductive life plan resource that was developed in Ontario is available on our website. Fetal alcohol spectrum disorder, commonly known as FASD, is a neurodevelopmental disorder. As alcohol passes through the placenta, it can affect the development of the fetal brain and central nervous system. Alcohol is a teratogen, and the Institute of Medicine reports that of all the substances, including cocaine, marijuana, and heroin, alcohol produces by far the most serious neurobehavioral effects to the fetus. As well, since the central nervous system develops throughout the entire pregnancy, there is a long time frame for exposure. According to the Public Health Agency of Canada, FASD is the leading known cause of preventable developmental disability among Canadians, whereas other developmental disabilities like cerebral palsy, which occurs less often than FASD, may only have some known forms of prevention. The updated Canadian Diagnostic Guidelines for FASD, released in 2015, report that the estimated prevalence of FASD in Canada is about 1 in 100 people. This translates to an estimated 5,000 individuals living with FASD in Halton. There are studies that suggest that FASD could be more prevalent, with perhaps 2 to 5% among younger school children in the US and many Western European countries. Ontario has recognized the importance of preventing and supporting those affected by FASD. In the newly released budget announcement, Ontario is investing $26 million over 4 years to expand support for children, youth, and families affected by FASD, as well as to increase awareness of the disorder and how it can be prevented. In the 2005 Canadian guidelines, FASD was described as the umbrella term for the 4 different diagnoses that were related to a spectrum of damage related to alcohol and included fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorders, and alcohol-related birth defects. Since the 2005 guidelines, the field has evolved, and additional evidence, expertise, and experience has emerged to suggest that a revision was required to improve both diagnoses and outcomes. One specific update is that FASD as a diagnostic term has only 2 subcategories, which are FASD with or without sentinel facial features. These features would be a short palpebral fissure, a smooth philtrum, and a thin upper lip. Now included is also a designation for those at risk for FASD who have prenatal alcohol exposure. FASD is not new to healthcare professionals, but it's a newer diagnosis. This diagnosis requires a complex medical evaluation and neurodevelopmental assessment conducted by a multidisciplinary team, including a physician, psychologist, and other allied health professionals. Each individual with FASD will present uniquely, but for a diagnosis, there need to be significant deficits in at least 3 central nervous system domains, which include areas such as motor skills, communication, executive functioning, sensory, and others. The individuals may have difficulty with planning, consequences, or impulsivity. They may be highly verbal but lack comprehension skills. Their balance and coordination may be impaired. They may be over or undersensitive to stimuli. If these concerns are not appropriately understood and addressed, individuals with FASD are at an increased risk for early school failure, involvement with the law, family disruption, and homelessness. It is not just the individuals and their families that are affected. It affects society through the healthcare system, mental health and substance abuse treatment services, foster care, the criminal justice system, and the long-term care of individuals with intellectual and physical disabilities. Most individuals with FASD do not fit the physical profile that used to be applied to diagnose fetal alcohol syndrome. Fetal alcohol syndrome was first used to describe the cluster of birth defects due to prenatal alcohol exposure, including the typical facial features that were associated with it. Only about 10% of individuals with FASD exhibit the common facial features: a smooth philtrum, thin upper lip, and short palpebral fissure length. These facial features only occur if there is alcohol exposure during the fetal developmental time frame of day 17 to 21. All of these pictures on this slide, which are from the YouTube video called Faces of FASD, are of individuals with FASD. It's important to remember that facial features do not determine the severity of damage to the brain. These individuals could be dealing with many neurodevelopmental effects discussed previously, but do not necessarily have any of the common facial features. Many individuals with FASD are able to live successful lives, but do so with stable supports. Although you may not see individuals with FASD in your practice, and you're not expected to diagnose FASD, many of you may have the opportunity to contribute to the prevention of FASD. There is strong evidence for the effectiveness of brief collaborative motivational interviewing approaches for reducing the risk of women having an alcohol-exposed pregnancy. In fact, a service provider who takes an empathetic, collaborative approach is one of the strongest predictors of whether a woman will be able to change her behavior. Prevention of many risks related to alcohol use, including FASD, may occur by simply starting the conversation about alcohol use. Having your patients comfortably discussing their regular alcohol use patterns, and then having their trusted healthcare provider reinforcing the low-risk alcohol drinking guidelines can help these individuals understand when they are at risk for health concerns. We do know that patients trust the messaging they receive from their healthcare providers. This gives you the opportunity to provide consistent messages, especially related to alcohol use for women. It is clearly stated in many resources that healthcare providers are ideally suited to screen for alcohol and substance use. By initiating routine alcohol screening in your practice, more prenatal alcohol exposure can be identified for possible FASD diagnosis later in a child's life. If you're familiar with the 4 A's of tobacco cessation, a similar model can be used related to alcohol use. The Society of Obstetrics and Gynecology of Canada recommends 3 A's for alcohol counseling, but I would like to highlight the initial part of assess, just starting the conversation about alcohol use with all women of childbearing age. If you want to reflect on the following: how comfortable do you feel asking all women of reproductive age about their alcohol use? Common barriers identified for not screening women for alcohol use is lack of time or not wanting to embarrass or offend women who are not consuming alcohol. It may be lack of knowledge of the alcohol treatment and counseling services that are available, or lack of training or comfort discussing alcohol concerns. By asking all women and letting them know that you ask all women, it may provide opportunity for an open discussion about alcohol use and start to normalize this topic. Once you hear the consumption habits, you can then move through to advice and assist and arrange stages as needed. How you ask is important. Use motivational interviewing techniques and open-ended questions. For many women, it is difficult to admit a concern regarding alcohol use during pregnancy. Women, especially when pregnant or with young children, this feelings of discrimination and lack of support for alcohol concerns, and may also fear child apprehension. This can cause some women to underreport their alcohol use. Routine alcohol screening, not evidence that preconception health can improve maternal and child health outcomes, such as preterm baby opportunities to honor FASD in children. In the past, many individuals they did not have any record of prenatal alcohol exposure. Asking can be as simple as, how does alcohol fit into your life? By screening, those are women 35 years of age or older, women who are sexual and emotional abuse, and women of high socioeconomic status. Tools are available and are effective for identifying at-risk alcohol use. The 2A's screening tool, which you can see on the left of the screen, is available on our website. Preconception. 4 simple alcoholism since most pregnant women waited to change their behavior. Among pregnant women, formal screening alone with the tools such as a TH has shown to reduce prenatal alcohol consumption. The TH tool is very similar to the tweak tool, which you can see on the right of the screen, which is also validated for pregnancy and which you can see on the right-hand side. These tools could be given to a patient to self-report prior to an appointment if timing is a barrier. Self-reporting may provide more honest answers. Risk and the College of Family Physicians Canada, based on the Canadian low risk alcohol drinking guidelines, is an effective tool. It has the benefit of guidelines for men and women and includes recommendations for pregnancy. It is important to provide key messages be reassuring. This is the first step for beginning brief intervention to identify some concerns. Brief intervention, feedback, and counseling. Alcohol counseling can be readily here. Using effective contraceptives. That 24% of Halton individuals feel it is okay to research stating a safe amount, but also stress it is never too late to stop or to get support. Current messaging related to which barrier to assessing alcohol use can be not knowing what works through and Halton. Two that can specifically identified with developmental concerns or that may have had prenatal to the Infant Child Development Services for developmental assessment active parent support group that runs out of the Burlington